Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dania Reynolds. In this episode, we focus on best practices for individualized care in older people living with HIV, including polypharmacy and deprescribing, the risk of cardiovascular events with various ART regimens, and approaches for managing weight gain. To address these topics, I'm joined by Dr. Roger Bedimo from the VA North Texas Healthcare System and the UT Southwestern Medical Center in Dallas, Texas. For more information about this program and to follow along with the slides, please visit the links in the show notes for this episode. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started as Dr. Bedimo shares a case.
So this is a 68-year-old Black man living with HIV, diagnosed 25 years ago, receiving dolutegravir plus FTC TAF. Past medical history is otherwise significant for type 2 diabetes, hypertension, dyslipidemia, and anxiety disorder. He reports 15-pound weight gain since starting the current regimen. Is frustrated by the number of pills. Other medications include metformin, lisinopril, hydrochlorothiazide, amlodipine, atorvastatin, venlafaxine, prazolam. So here are his numbers here. The grade CD4 count is over 500. Viremia is undetectable. He's immune to hepatitis B. He's negative FC. He's not HLA-B5701 positive. So Bacavir, should you choose to do so, would be okay for him. BMI is on the obese category, over 30. No resistance-associated mutations. LFT is a tidbit elevated. Aging with HIV. Now, we already know that the median age of people with HIV keeps increasing, over 50 in most clinics now, and the survival is no longer driven by AIDS-related complications or opportunistic infections, but it's driven by non-AIDS comorbidities. And so this is important to consider them. These comorbidities may occur at an earlier age or at a greater frequency in people with HIV. And so it's important, and then frailty is important to manage as well. And here's the problem. The problem is that to manage all these comorbidities, medications keep piling on people. Now, we already have this definition of polypharmacy as using 5 or more medications. It's not hard to reach that target anymore in aging people with HIV. This can increase pill fatigue, decrease in adherence, increase drug-drug interactions or adverse drug reactions. The medication could make them frail. Now, just by managing hypertension aggressively in these older people with HIV already have sarcopenia and frailty, you might decrease the blood pressure too much and they may fall. And so you have to now manage a number of competing issues. And also polypharmacy is now one of the strongest predictors of serious adverse drug reactions. And those response association with all CVD morbidities has to be balanced. So how do you do that? When you look at ART, of course, undetectable viremia is the goal for everyone. And however, we need to look at the history, see whether there are archive resistance detected. We need to lower the pill burden, make sure we manage or reduce the risk of drug interactions and toxicity. And for the non-ART drugs, the fewer, the better. Deprescribing is important, should be first and foremost in your head. People usually end up on drugs that they started when they were in the hospital for something and nobody ever discontinued them. The target should always be to minimize polypharmacy, even as we want to be aggressive in managing the comorbidities that are important in these people. So this is the POPI study, polypharmacy and drug interaction in older and younger people living with HIV. It was a bigger problem in older people, no surprise here, over 50. And people living with HIV and over 50 had even greater risk of polypharmacy than people without HIV, and people with HIV were under 50. So raise awareness. We should all be mindful of this. Now we have a concern that, again, I should say that this has not been proven by all studies, because there were previous studies that suggested that integrase inhibitors did increase the risk of cardiovascular disease in people with HIV. That's why everybody breathes a sigh of relief when this particular study in the Swiss cohort did not confirm this risk. And this study is a longitudinal study that emulated treatment trial of people who initiate INSTIs versus other ART. And again, that was very nicely done to account for all the possible confounders and probability of treatment and censoring weight. So this study had a pretty good number of people, and for people on INSTI, much more of them, a greater proportion of them, 23%, were on abacavir, which we already know is somewhat associated with a risk of cardiovascular disease than in other ARTs. So that is one thing to be mindful of. So if you don't adjust for all these things, you come up with a finding that integrase inhibitors INSTIs were associated with an increased risk of cardiovascular events. However, after you adjust for all these other things, including other antiretrovirals that they use, just like abacavir, what time, what year, and so on and so forth, you see that there was no difference observed in adjusted cardiovascular event incidence between INSTI-based ART and other ART. So this is a welcome news. Again, we need to continue to stay vigilant because for those of you who have been in HIV care for over 15 years, you know that back in 2008, 2009, we had similar issues with abacavir, some studies showing that it's associated with increased risk of ASCVD. Other studies say that it's not. So we hope not to get to this type of conundrum. So, and this is the previous study that I mentioned earlier. This was the so-called RESPOND cohort in Europe and Australia. In this particular cohort, they had showed that initiating integrase inhibitor was associated with an increased risk of myocardial infarctions or cardiovascular events within 6 months of initiation, and that risk decreased thereafter. So risk of CV events increased in the first 24 months and was not observed after that, which remains in contradiction to the previous study in the Swiss cohort. So we don't know what the answer will be. What we also know is that this is a meta-analysis, a pooled analysis of several trials of initial antiretroviral therapy in previously antiretroviral naive patients that suggests that being female and being Black are both risk factors for increased weight gain on antiretroviral therapy. And that is important to bear in mind, especially therapies containing integrase inhibitors or tenofovir alafenamide. So integrase inhibitors were associated with higher risk of mean weight gain than the other so-called anchor drugs, PAs or NNRTI. Within the integrase inhibitors class, it appeared that the newer ones, the second generation integrase inhibitors, bictegravir and dolutegravir, were associated with a higher weight gain than the older one here, elvategravir, cobicistat. And within the NRTIs, tenofovir alafenamide was associated with a greater weight gain than abacavir, and the lowest weight gain were observed in people on TDF and AZT. So can anything be done about that? And some inkling of an answer from the characterized cohort in South Africa, where they followed the advanced study. The advanced study did randomize people to receive dolutegravir FTC TDF or dolutegravir FTC TAF or efavirenz FTC TDF. The long story short is that people who receive dolutegravir were more likely to gain weight than people receive efavirenz. And if dolutegravir was received with TAF, there was even greater weight gain than if dolutegravir was received with TDF. So that was advanced. Now, after advance was closed, South Africa had a programmatic change that most people, the formulary essentially changed, and people were all referred to dolutegravir TTC-TDF. So people who were previously in advance who were then switched to dolutegravir TTC-TDF were followed in the so-called characterized study. And in that follow-up, they observed that if you were in dolutegravir FTC-TAF and switched to dolutegravir TTC-TDF, you lose weight. If you were in efavirenz FTC-TDF and switched to dolutegravir TTC-TDF, you gained weight, which makes sense if you look at the previous finding. However, there has been no great evidence thus far that people who gain weight in any regimen containing INSTI and or TAF would lose weight if you change the regimen. This is one of the findings of the so-called DEFINE study, which shows that there was no difference in weight change when you switch people who were receiving darunavir, cobicistat, FTC-TAF to when you look at virologically suppressed patients who gain weight, and if you switch them to darunavir, cobicistat, FTC-TAF versus INSTI, FTC-TAF, and then switch to darunavir, cobicistat, FTC-TAF, there was no significant difference in weight change. So if you were on INSTI and FTC-TAF, switching you to darunavir for FTC-TAF, i.e. substituting darunavir, cobicistat for the INSTI, did not change your weight trajectory. So the bottom line is this: if you were on a regimen that contains INSTI and or TAF, there is no good evidence that switching you to a protease inhibitor-based regimen or an NNRTI-based regimen will significantly affect your weight. Maybe that evidence will be forthcoming, but we don't have it yet. So we do not recommend people to switch exclusively for the weight. So this is what the DHHS guidelines said, that significant weight gain may occur with all antiretroviral regimens, but it appears to be more pronounced with dolutegravir, bictegravir, and TAF. So counsel your patients on lifestyle modification and dietary interventions. I always say that we owe our patients candor before we initiate the treatment. So tell them that we're starting you on this regimen, you might gain weight. If you don't do that at the forefront, you may lose their confidence. And so our ARV-associated weight gain should be a factor to consider when initiating, honestly, especially for Black women. And I think for me, it's simply telling them that this is a possibility. Most people do not gain weight, but some might, and you may be more likely to gain than most because you're a Black woman. Not necessarily that I want to give you a different regimen because of that. So to date, it remains unclear whether switching to a non-INSTI-based regimen will result in a reversal of the weight gain. So don't do it simply for that reason. The underlying mechanism of weight gain, unfortunately, and the impact on cardiovascular disease, diabetes, and other outcomes remains unknown. This is frustrating for everyone, especially our patients. So what's the take-home message for the older people with weight gain and comorbidities? Is that people who, as they age with HIV, thanks to wonderful antiretroviral agents, are now at risk of a number of comorbidities that can occur at a greater frequency in people with HIV. And with that come the risk of polypharmacy to management. So deprescribing should always be considered. And then adjustment for other contributing factors. Adjusting for other contributing factors, the Swiss cohort did not show that INSTIs were associated with increased cardiovascular events. We hope that that is going to be the final truth. And then weight gain appears in those who start TAF versus TDF, in those who start INSTIs, especially if the newer INSTIs, bictegravir and dolutegravir, compared to NNRTI and PI. So there's no evidence that switching ART for those who gain weight on INSTIs or TAF will reduce their weight.
Thank you very much to Dr. Bedimo, and thank you to our listeners for joining in. Get access to all of our new podcasts by subscribing to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.